this slide serves as my introduction and my disclaimer. Steve gave you some idea of what SaferMD does, and get more into that later. First, clarification about terminology. The American College of Radiology first talked about reportable test results in their policy on communication in around 2000. And a reportable test result is any finding that is either unexpected or emergent. Like, for example, the density we see at the right lung base here, which needed a follow-up CAT scan and turned out to be a tumor. The terminology was the spotlight for the terminology was taken over by the Joint Commission, which accredits hospitals, when they adopted the term critical test result and critical test. Critical result is really a panic value. It's something that has to be reported immediately or will have immediate deleterious effect on the patient. A critical test, on the other hand, is an exam that, when ordered, has to be performed and interpreted and result back to the clinician within an hour of the order time. As part of their accreditation process and inspection of hospitals, they look for policies and documentation to comply with those policies. This may seem redundant, but from the data that we're looking at, both proprietary and non-proprietary, it seems that failure to communicate may account for over $3 billion in annual malpractice indemnity, covering both facilities and caregivers. Physicians and other reporting entities, as I mentioned, can use safer reporting practices to greatly reduce or eliminate this liability. But how do we get them to do it? How can we leverage this liability exposure to improve patient safety? Welcome to Healthcare Management 2010. Having worked in hospitals, I can tell you that the current system of managing facilities and caregivers is analogous to a baby carrot, a big stick, and a broom. And everyone knows what the baby carrots are that we get in the grocery store. Sorry I didn't get a good graphic for it. But it's a baby carrot because the best example for it is in Medicare's Pay for Performance program, where if the physician's panel of patients has good outcomes, they can end up with a whopping 2% reward if they meet all the other reporting criteria. I don't know if that has been enough of a factor. I don't know if it's been proximal enough to the actual treatment to make a big change. However, sticks we've got. Hospitals' accreditations can be removed. Physicians' privileges can be taken away, as well as their licenses. It's also occurs at the department level. There's peer review and morbidity and mortality conferences. And finally, the broom. Anytime something goes wrong in a hospital, there has to be a root cause analysis or a sentinel event committee meeting. And those take quite a bit of time to go through all the systems and figure out what went wrong. Insurance systems, both in terms of indemnity for malpractice and healthcare, are designed for prevention, and that's the language that we use: preventing disease, preventing people who are unqualified from treating but requiring certification, preventing cost, for example, capitation for providers, and preventing complications of disease. There's the Medicare never events, which people are familiar with. There has been some recent data suggesting that although you don't want patients getting bed sores, it is not really a financial incentive that gets that prevention, because the cost to prevent never events actually exceeds the economic benefit. And so it seems to me that we might be able to do better. I'm extremely confident that if we were able to concentrate more of our efforts on helping people doing a better job instead of just thinking about keeping them from messing up, then there might be less need for the broom and the stick. So the golden rule that is more traditional is treat your neighbors as you yourself would want to be treated. What I used to hear when I was a kid, who has the gold makes the rules. And the question is, who has the gold? And I would suggest that some of the people in this room have the gold, and they might be able to change the rules. We can help physicians practice better, as I mentioned, by looking at where they're messing up and giving them what they need to do a better job. Physicians, as you know, are increasingly busy, they're running around the hospitals. No wonder they're missing test results. How can we get them the information they need when and where they actually need it? Well, one way is to motivate the doctors who are doing the diagnostic work to report in that manner, especially with regard to abnormal critical test results. But then, that sounds like a great theory, but how do you actually do it? What information would you use to incentivize diagnostic physicians and facilities? The problem is that financial incentives, like rewards, can really skew the data. Here are a couple articles from this month. The Wall Street Journal, there's an article, Perk of Power, about elected congressional representatives and their aides who were trading on companies and industries that they were overseeing. People are familiar with Avandia, the diabetes drug, which turned out to have complications of myocardial infarction. And in the British Journal of Medicine, BMJ, they found a slant, and because there are a fair number of articles in favor of Avandia written by paid consultants. Those articles that were not written by the paid consultants had a much more neutral tone, and this was actually statistically significant. So, as in other industries, third-party auditors have been able to provide more reliable means of documenting physician risk reduction activities. For example, we could tell if critical test result management services, like Secure Reach, are actually what they say they are, if they meet certain minimum performance criteria. And it could enable malpractice carriers to profit from reduced liability exposure. And using these safety metrics, they can strategically target the discounts. Because although carriers are actually giving credits to install these systems, they don't know if the physicians are using them, because there hasn't been audited safety usage data available until now. It's kind of like giving someone a discount for a smoke detector, but you don't know if they're actually have a battery in the smoke detector. The usage data solves that problem. And the workflow would be something like this. The critical test result management service would provide usage data to the auditor, who would, for one thing, make sure that there's no retroactive documentation, make sure that the message data follows certain business rules, and certifies it then as credible. Provide that to the carriers, who can then, on the basis of that data, provide incentives to facilities and individual physicians. And I think this is a step in the direction of helping people do a better job. So that's all I have.